Thank you so much, Diabetes India, for giving me an opportunity to speak on this topic. It's very burning topic today of obesity, diabetes, and now we have a miracle drug that would actually show some concrete results. Uh, it's a game changer. It is something I would say one drug after the insulin that actually does everything better. It is good for diabetes, good for weight, good for heart, liver, brain, inflammation, you name it. But one thing that we need to keep in mind that rapid weight loss can have some deleterious things that we need to keep in our mind, and that's what I'm talking about is sarcopenia. First, not many people address this. It's difficult to measure, and we'll come to that. But this is going to be a major quality of life indicator. We all in the medical field try to extend the life. The length of life is important, but then what's the quality in that long life? And one we just talked about the dementia, that is one of the major quality of life indicator. The second one will be your muscle mass or muscle performance. The lean mass drives the physical function, independence, like how much you can be even going walking to the bathroom, doing your daily activities. And in elderly population, one of the key incidents that can lead to debility and death is fall. So sarcopenia or the loss of muscle mass is actually extremely important as we grow older. In addition, skeletal muscle is a major site of glucose disposal and insulin sensitivity, which we know. That means like decreasing the muscle mass will increase the insulin and the whole yard of the things that go with metabolically. When we lose weight, and I'm coming to that in a detail later, but basically we always lose muscle. Whether it's your starvation, whether you are doing by the bariatric surgery or doing by the GLP-1, there is a muscle loss. When you lose the muscle, you lose basic resting energy expenditure. So for example, if I eat less, I spend less because body tries to conserve energy. Then I eat even more and body tries to conserve. Now, even a little bit of more food is actually excess food for the metabolic expenditure that is related to the muscle mass. So starvation induced or dietary induced loss is key in promoting weight regain. Older adults, chronic disease, weight loss alone is not important. What you see on the weighing machine is only a part of it. How much muscle they are losing is also important. The measurement of it or the clinical parameters are little difficult. I mean, sarcopenia was not even a term until 1989. And clinician didn't know how to actually measure. We have the fat measurement of the subcutaneous fat or something, but for lean mass. So the European Working Group of Sarcopenia Older People Framework came together in 2009, and then they revised it. The number 2 is for 2018. What they think is you first suspect there are many secondary causes of weight loss like cachexia or the inflammatory chronic diseases or end-stage renal disease, etc. But even just otherwise healthy, you go to weight loss, you suspect patient says low energy. Then the assessment, which measures the muscle mass. Now, sarcopenia alone, if one person measures a muscle mass, doesn't tell me much. Only time it means something that whether it affects the performance, whether it affects his clinical activity, that matters. So we need two definitions for sarcopenia: actual muscle mass loss and performance loss. Other time it is useful to measure is when you are looking serially in the same patient over the time. In that case, we don't have the standard deviation definition of, okay, your measurement is this and you are sarcopenic. The confirmation and the severity are the two aspects of the measurements. So we start with the low muscle strength. That's a primary parameter, probably sarcopenia. Then we confirm that measuring the muscle mass. Now this is still not accurate or perfect science. The ideal gold standard would be the BOD pod, like a plethysmography with air or the underwater measurement, which done in the clinical settings. The closer, more accurate, about 90% comes with a DEXA, but that involves two-compartment model with a radiation. Less invasive is a BIA, bioimpedance electrical assessment, where you get to stand on the machine and put the electrode on the hands. Accuracy is around 80%, and there is a lot of intrapersonal variation. And CT MRI also give you some idea, but these are not something that you normally regularly. And even if you document the muscle mass, you need to follow that over the time. On the other hand, clinical measurements where you can actually see the patient's performance, that can define the sarcopenia, where there is a short physical performance battery. They are the four that we can do it in 5 minutes clinically. And I'm actually going to stay together. There's a half tandem, which means you are halfway connected, or the full tandem. And also you walk for a 3-meter distance and see how much you can walk. And the last one is a chair. Sit and get up, sit and get up, how many times you can do in 10 seconds or something. Now these are the performance measures. These are not just number of muscle mass, how much percentage it is. It's actually how it affects your clinically. So that is important when you decide how much relevant it is. And also remember, BMI doesn't tell you all story. A person may lose weight, the BMI may come down, but an obese person can be seriously sarcopenic. So when you say that the person has lost weight and is doing good, now the BMI is 24, doesn't tell you everything. At the same time, a 35 BMI is not all the, can have a relatively excess fat. So you can have a sarcopenic obesity. Now, of course, clinical implication is low muscle reserve matters. Now, what happens during the weight loss, whether it is from the diet or anti-obesity medicine or bariatric surgery? Anytime there is an energy deficit, there is a gluconeogenesis which burns fat as well as muscle to create the energy. You lose fat, feels good, lose muscle at the same time. Most of these people are not doing mechanical loading. And here I'm going to talk about later exercise, where it's not just the exercise like walk or aerobic, it's a resistance exercise. So if you do not have the muscle mechanical loading, there is no stimulus to the growth for the muscle, and that reduces the muscle protein synthesis. As we age, there is a decline in the muscle mass because of the muscle breakdown, but the synthesis also gets reduced. So we have more breakdown, less synthesis, and then aging factors like inflammation, resistance, they all amplify the muscle loss. Dietary intake of protein also matters. Now here is one thing, that if you just increase 10 gram per kilogram protein, that's not going to increase the muscle. Muscles increase only after the resistance loading. We need sufficient protein for that. So less protein matters. Reaching 1 to 1.2 is necessary to maintain that growth of the muscle in addition to exercise. The particularly worst hit are the post-bariatric people, because there is a intake goes low and surgical recovery delays the strength training. So how much lean mass is typically lost when you lose weight? Diet only loses about losses have roughly 75% is fat loss, 25% is muscle loss. When you do it with a GLP-1 based therapy, the data is all over the place. It's a heterogeneous, but again, it averages at 25% fat loss when you lose the weight. Higher weight losses I just mentioned with the bariatric surgery, where we are going almost 35% loss in the first year. And here is the first part. If you lose after surgery, say 50 pounds, 25 kilos in 1 year, half of it is lost in first 3 months. So that is the early loss phase, is the most important window where you should act. So 55% is lost in first 3 months. Assessment is not, as I said, exotic tests are necessary. Clinical bedside tests would give you that. So you should screen the high-risk patient with older age, frailty, rapid loss, post-bariatric. Hand grip dynamometry correlates pretty well to the lower extremity muscle strength. So we can use that in clinical picture. And as I said, 5-chair stand. Objective measurements we talked about, and gate speed, performance, battery, stair climb, etc. These things you can use clinically, but then document that and then follow it up over the time. Tracking of the trend is important over 3 months and 12 months, and that will give you the idea of muscle gain. Now, our goal is preserve muscle mass while reducing the fat mass. If only one word you want to take out of this talk home is resistance training, and strength exercise. That's the only way to increase the muscle mass. Unfortunately, 90% of the people, India or the US, do not get the minimum requirement of the exercise. And those who do tend to do more like walking, running, or the aerobic exercises. It's not in our culture that elderly or general people can do some weight training. You don't have to go to the gym. Your body weight exercises are available to do the weight strength training. But that needs to be done. That awareness needs to come. Caloric restriction, lean mass declines compared with people who don't do the training. What weight training does is, at least it decreases the loss. So you will still lose the muscle. Somebody who is doing physical training will lose less. At least it will maintain. Protein intake 1.2 to 1.6, that's actually very tough, but especially with the vegetarian population, it needs to be in the, if you consider milk, egg, and meat are the leucine-rich diets, the milk is our vegetarian included in that. Now, when we do the GLP-1 or the bariatric patient, the appetite drop automatically decreases the total amount of food that you eat, which means total amount of protein also decrease. So we have to be careful in decreasing when you eat less, maintain a specific thing, attention to composition. And remember, the protein is not stored. Fat can be stored, carbohydrate can be stored. So it's a daily intake. In fact, distributed intake over the day. Little protein in each meal is important. Changing the gears, I have given this talk with the 2 parts. So second part is going to be a little interesting, that all I talked about how weight loss can give the bad things. This is something that can give you a good thing. The sexual function related with obesity and how weight loss changes with that. So we know that the obesity leads to sexual dysfunction. Higher BMI, central obesity are consistently associated with erectile dysfunction in men. If you look at the odds, if you are overweight, there is a 30% risk of ED, while you are obese, there is 60% higher incidence of the ED in men. Even in there are not many studies, but if you see the cross-sectional or the pooled studies, it has been direct correlation between the female sexual dysfunction. Even though heterogeneous, it kind of half of them, if they are obese, will have the FSD. Comorbid conditions make it worse. Type 2 diabetes, hypertension, obstructive sleep apnea, depression, and then the medication. The primary reason why the sexual function decreases is the vascular supply, and that correlates with the diabetes-related vascular disease. Both men and women depend on the vascular supply. So in men, the mechanism is interesting. Visceral fat gives you more leptin, more cytokines. It works on both the ways. It decreases your testosterone and increases estradiol because you have a more aromatase. But it also increases the inflammation. Both of them increase insulin resistance. And also there is a decreased nitric oxide availability and decreased blood flow leads to erectile dysfunction. So endothelial dysfunction is one of the drivers there. Then sleep apnea and the medication on top of it can give rise to more causes of sexual dysfunction in men. In women, metabolic and vascular changes are common mechanism with the diabetes can impair the arousal, lubrication, orgasm. By the way, I'm going to cover very little because at 2 p.m. we have a full session of multiple stellar talks about female sexual dysfunction in general related with diabetes. And one talk I think I missed yesterday was there also. Dr. Lily spoke very nicely about it. PCOS, menstrual dysfunction, can add the dysfunction. Pelvic floor disorders, including inflammation, can cause dyspareunia. And obesity-related depression, stigma, and body image also decrease the self-esteem. And self-esteem has a lot to do with arousal or sexual function. So these are the mechanisms. Now, does that really improve? Say, for example, if you lose weight, what's the data? What evidence we have? So These studies were done in Maine, and what we have is IIEF, International Index of Erectile Function. It's a 15 question questionnaire, and the short version is 5 questions. Actually, this has been very popularized after the Viagra in 1998. This is the first time people objectively started documenting erectile function. And when you lose weight, this one was done with a 2004 trial. This is pre-GLP-1, so the weight loss was mainly diet and the increased activity. The comparator was usual care, and in the treatment group, the BMI fell from 36.9, almost 37 to 31. Same in the control group, but the IIEF score, which maximum is 22 and above, increased from 13 to 17 in the treatment group, while unchanged in control, and almost 1/3 of them achieved normal score. So yes, diet, exercise-related weight loss definitely improves objective measure of sexual function in men. The data was actually normalized for other reasons, like whether the BMI alone was a cause, whether the physical activity or CRP. Independent of that, just the weight loss alone gave you the improvement. In women, the data is much less available, but the look ahead study, which was back in 2013, where we did the cardiovascular benefits of semaglutide, but the weight loss, sorry, not semaglutide, weight loss, their sub-analysis actually showed that 50% of women in the study group met the criteria for FSD, and 1 year weight loss from about 7.6 kilo in the treatment group caused remission of the FSD of almost 28% as opposed to 11. So yes, there is some data that says even in women, losing weight gives you the improvement in the sexual function. Improvement was more strongest in the women who had more dysfunction at the baseline. Now, coming to the anti-obesity medicine, now the era of the GLP-1 we have, what do we have? So these therapies cause meaningful weight loss, as we mentioned. There are cardiovascular benefits, so vascular supply also should get better. The most of the data is coming only in the last year in 2025. This study where they had 110 men with type 2 diabetes, their testosterone improved, and libido and erectile function. In fact, there is one study, it was actually a meta-analysis of multiple randomized trials. It showed improvement in the semen quality also. So yes, GLP-1 does good things in addition to all other. This is one more. Bariatric surgery actually has more impressive data, and it's been around longer time, and the amount of improvement, extent of improvement is more after bariatric surgery. There is a meta-analysis in 2023 where erectile function domain scores increased by 4.8, and you can see all of them, they improved. And the actual testosterone increased by the level after surgery. In women, the FSFI, this is also a term called as female sexual function index, that improved after the surgery. So if you think of, just like a previous speaker said, that everyone will be on GLP-1, and which I think will be once the cost comes down. Worldwide, millions and billions of people are already on GLP-1s. They will have tremendous benefits on diabetes-related complications, cognition, liver failure, kidneys, Alzheimer, as I just said, inflammation. There are so many people with arthritis or the chronic inflammation or pain are feeling much better. Rheumatologists are prescribing it more. De-addiction, there is a lot of data on the decrease alcohol. In fact, there are decrease in alcohol sale in the population who are on GLP-1. So with all this, we need to keep in mind that resistance training, regular exercise is important to mitigate the one side effect, and then with improved sexual function, most people will be happy. Thank you.